We are good to go. We are live. Thank you so much.
Okay. So again, thank you guys for joining us today. I hope we've got some information you'll take with you. Now on to the show. We wanted to get you guys together to talk a little bit about the electrical concepts, or actually give you some basic knowledge of pacemakers and why we implant pacemakers, who they're implanted in, and some concepts associated with those so you'd be more familiar. So the first thing I'd like to start with are basic electrical concepts of pacing and what we're doing with pacemakers in general. To begin with, what are our goals? First and foremost, we want to prevent somebody's heart from going too slow. How do we do that? By inserting a pacemaker and pacemaker leads into the heart and delivering energy to the heart, allowing the heart to contract or depolarize. We also use those same wires to sense intrinsic activity in the patient. So those wires serve two functions: as an antenna to sense intrinsic rates, and as a delivery tool to send electrical current to the heart to make it capture. Those two functions are influenced by a bunch of different parameters. For instance, we can set the voltage and the amount of time we send an electrical impulse to the heart to make it contract. We can also set the sensitivity as to what we're looking for from the heart signal itself. And we're also concerned about the impedance readings on the lead, and we'll get into that in a few minutes. So these are a couple of electrical concepts that we're going to be going over. To begin with, let's talk about the output, or the two things that affect the output, the amount of energy going to the heart to make it contract. The first is the pulse amplitude, and the second is the pulse width. So we can vary the amount of current going to the heart or amplitude by increasing the voltage or increasing the amount of time we're sending a voltage to. That's two very important concepts there. So when we do that, we're doing that in order to capture the heart, okay? And when we capture the heart, we're making it depolarize. So when you hear the term capture threshold, it is the minimum amount of electricity it takes to make the heart depolarize over a specific amount of time. When it causes depolarization, it's called capture. Excuse me. Capture threshold is also called the pacing threshold or the stimulation threshold. And it's important to note that those thresholds over time can change. And why can they change? Well, because people change all the time. Their disease states change over time. Various medications can affect pacing thresholds, and age. You know, lots of different things go into it. Like it says, it can even change over the course of the day or course of time, as we see with leads that are in for an extended period of time. By the way, you guys feel free, if you have a question midstream, jump in and ask, and I'll be happy to stop and kind of review that. So going forward. So when we originally put in a lead inside the heart and affix it to the myocardium, there are a couple different concepts you need to know. The first thing is that lead can either be a fixed or screwed or a active fixation lead, which has a little corkscrew that screws into the myocardial tissue, or it can be a passive lead, which has tines that kind of hook into the trabecula of the heart to keep it affixed next to the myocardial tissue. Well, on the tip of the lead, we have an electrode. And if you see the little blue line, what that creates when we try to do pacing is a virtual electrode. We have non-excitable tissue that scars around that, and then the excitable tissue, which is the actual myocardium. An interesting concept if you look at the graph to your right, over time, when we originally implant the leads, we try to get the lowest possible reading on that threshold. But over the course of years and time and varying conditions with the patient, that tends to go up. So at implant, it's very important to get a threshold as low as you possibly can, because over time, we'll see those thresholds go up. And with thresholds going up, that affects battery longevity. So it's critical at implant that we get the best possible threshold that we can. So what affects capture thresholds? We talked a little bit about this. Activity level, posture, time of day, various comorbidities. Drugs have an extreme effect on thresholds. Disease progression, what you eat, your status of heart failure. All of these things combine to affect capture thresholds. So when we implant and we put a brand new device in somebody, I told you we're looking for the really good threshold at implant, because over time they tend to go up. So just as a note, keep in mind when we're implanting in the atrium and the ventricle, in the atrium we're looking for a minimum threshold of 1.5 volts. Okay, that's what we're looking for. In the ventricle, 1.0 volts. Over time, those chronic thresholds will creep up, and we want them to stay below 2.5 to maintain good battery longevity. Now, every patient is different. Will we see patients with high thresholds? Absolutely. Doesn't necessarily mean that we'll have to go back and revise the lead or have another surgical intervention. We might just accept it depending upon the age of the patient and so forth, or comorbidities. But it's very important, as you can see, we don't want that battery to run out. Let's say our typical batteries last 12 years in our pacemakers. If we have a high threshold, that can reduce the longevity up to 40%. So we're trying to maintain so we have the least amount of interventional surgeries as possible for that patient. So after implant, we want to set the output of the device with a proper safety margin to manage the effects of day-to-day influence on that patient's well-being. We call that the capture safety margin, or the safety margin for the patient. In the past, we used to usually just double the amount of output or double the pulse width in order to do that. Over the course of time, various different algorithms were incorporated into the devices, and our algorithm actually checks the output of the device beat by beat in order to optimize the output of the device. So every beat it's looking for capture. If it doesn't see capture, it sends a backup pulse so that patient never stops capturing. If it sees loss of capture, it'll do a backup pulse and then immediately then do a capture threshold test on that patient. And we'll optimize the output level at 0.25 volts above whatever their capture threshold is. So that algorithm, on a side note, is called auto capture. The second electrical concept that I wanted to go over with you is sensing. So every heartbeat you have produces an electrical signal in your heart. We measure those in various different ways through the surface ECG, internally with leads through EGMs. And when we're implanting or when we're looking at a patient who has a pacemaker, we want to make sure we can see if they're having intrinsic activity, okay? So what we can do is set a sensing threshold. And that sensing threshold, I like to kind of think about it as a fence. If you make a fence too high, you can't see over it. If you make it too low, you see too much. So we're kind of looking for the sweet spot there. So we set the sensing threshold usually about half of what the R wave or the P wave that we're seeing intrinsically is measured at, okay? So cardiac sensing thresholds, kind of right now, they're expressed in millivolts. So when we're measuring these electrical signals in the heart, they're very small signals, but we want to make sure we can still see. So typically, when we're talking thresholds, we want to see R waves greater than 6 millivolts. And when they're greater than 6 millivolts, we'll set our sensing fence or threshold to 3 millivolts. P waves are a little bit different. P waves are a little smaller just by nature. So we're looking at implant for P waves over 1.5 millivolts. So our sensing threshold will be much lower. If you guys all follow that. If not, please jump in. The third and final electrical concept that I wanted to kind of go over with you guys is impedance. And what impedance is the sum of all forces opposing the flow of current in a circuit, okay? So that wire, when we're sending it, there are forces that inhibit its flow through that lead. So we want to make sure that the lead has the ability to conduct. That measurement, excuse me, that measurement is measured in ohms. Pacing leads in typical impedance ranges, I disagree with this a little bit. I would say they're from 200 up to 1900, depending on the lead that you're using, okay? If they fall outside of that parameter, those parameters, we start looking for problems, because the lead is in constant motion, okay? It's the only moving part to this pacemaker system, and it's more susceptible to failure than anything else in the entire system. So things that can affect impedance: resistance of the conductor coils, tissue interface, the size of the actual electrode surface area, and the size and shape of the tip of the electrode. Let me go back here for just a second. So things that we look at when we're looking at implanted leads and implanted pacemakers are, if these fall outside of parameters, what's going on with the patient? If we see impedance readings too low, it may be indicative of the outer insulation failure and some current leaking out of it. So we look for that. Impedances being too high could mean there's that current isn't reaching the heart, and that's indicative of a lead malfunction or breaking. The last function that I wanted to talk to you about pacemakers, and I'll add defibrillators onto this, is what happens when a magnet is placed over the device. Two very different things happen when a magnet's placed over the device. On the pacemaker side, what happens is we change modes. We change from being able to sense to telling the device that we're just going to pace. So it's going to pace asynchronously, depending on what that particular device is set to. So if we place a magnet on a pacemaker, typically it'll pace at its magnet rate, which for our devices is anywhere from 100 to 85 beats a minute. Now, placing a magnet over a defibrillator is something quite different. So defibrillators are used A, as pacemakers, and B, as a life-saving device in case somebody goes into a ventricular arrhythmia. If they go into a ventricular arrhythmia, if we go into a ventricular, excuse me, I just got a message from Zoom. If we go into a ventricular arrhythmia, VT or VF, we can send really fast pacing signals to the heart to get that patient to break out of that rhythm, or we can send a shock to the heart to get them to break out of that rhythm. Now, in this case, placing a magnet over the device does not change the mode and just asynchronously pace. It actually prevents ventricular therapy from happening. The reason we have that feature in the device on a defibrillator is when patients go in for surgeries, we don't want the electric cautery to affect their device and make the device think they're NDF and send shocks, okay? So that's those are the general electrical concepts that I wanted to go over with you before we dove into indications for pacemaker therapy. Why do patients get pacemakers? Well, if you want to know why they get pacemakers, you got to kind of know the electrical system in the heart. So they're just like a car, a boat, a house. Everything has a plumbing system, an electrical system, and various other systems. But we're primarily focused in the electrical system here. So if we take a look at the heart, we've got basically 5 electrical components that we deal with inside the myocardium. Those are 1, the SA node, the AV node, the bundle of His, right and left bundle branches, and the Purkinje fibers. The body's natural pacemaker lives in the SA node. It's got the unique ability to start the whole process of making the heart contract. It's called automaticity. It starts the heart to contract. A normal healthy heart fires anywhere from 60 to 100 beats a minute and causes depolarization in the atrium. That wave travels through the AV node and conducts down to the ventricle, which causes the bottom half of the heart to contract as well. The AV node is the body's own secondary pacemaker. So what's really cool about the heart, I think, is we have triple redundancy. And what I mean by that is if the AV node fails, if the SA node fails, the AV node typically kicks in, and it has an underlying automaticity rate of 40 to 60 beats a minute. It's located in the lower right atrium, right above the tricuspid valve. It's slightly slower, and the electrical impulse travels down the AV node to the ventricles next. There's also one other rhythm before we get to the ventricles that I'll tell you about, and it's called a junctional rhythm. Junctional rhythms are usually around 40 to 60 beats a minute. We see these a lot in congenital heart block patients, where it has a narrow QRS and no P wave, because the P wave is actually happening as the ventricular depolarization occurs. So we'll get into that in a little bit. Then we have the bundle of His, that leads to the Purkinje fibers where the electrical activity propagates and goes around to make the ventricles squeeze. Those are the right and left bundles and the Purkinje fibers. So here is the triple redundancy, the last level of security for us. It can create signals from 20 to 40 beats per minute. When we see those kind of signals, those people come into the ERs and they get pacemakers generally pretty quick. So defects of the conduction system can be caused by a variety of different things: coronary artery disease, idiopathic degeneration, viruses, calcification, endocarditis, heart surgery, ablations. So indications for pacemakers, you can see those on the left, okay? And you can see the documentation needed to implant a pacemaker as well on the right. So who needs a pacemaker? In general, pacemakers are indicated for sick sinus syndrome, heart block, and neurocardiogenic syncope. And let's dive into those just for a few minutes. Sick sinus syndrome is a class of disease states that include bradycardia, sinus arrest, sinus block, Brady-Tachy syndrome, and AF or atrial fibrillation with RBR. Okay. Inherently, bradycardia is any rate less than 60 beats a minute. It may or may not present with AF or other associated heart rhythms. So this is a good example of sinus bradycardia, and if you can count here, let's see, 300, 150, 100, 70, 60. So this isn't terrible bradycardia, but that's in the 50 beats a minute range. Sinus arrest occurs when the sinus node just fails to produce an electrical current. On the left, you see 3 nice beats and then a drop, and then the sinus node kicks back in. It's pretty similar. It's similar to A node exit block. However, a little different. We won't get too far into that, but these patients are indicated for pacing. Sinus arrest, it's a good example. Sinus exit block. What is Brady-Tachy syndrome? Bradycardia is always, this is where bradycardia is always accompanied by some atrial tachycardia, okay? When the atrium's going really fast, the ventricles can go really fast, or they can go really slow. So in both cases, those patients are indicated for pacing if we can't control rates with medication. So this is a good example of somebody who definitely needs a pacemaker. They're in an atrial arrhythmia, they're going really fast, and then all of a sudden they slow down. These people tend to DFO or fall right on out. So we generally put pacemakers in those patients. So there are two types of, so when we're talking Brady-Tachy syndrome, you've got one Brady-Tachy syndrome, so you're in AF with a slow ventricular response. That's the EKG on the top. And then you'll have somebody with fast ventricular response. You may think to yourself, why do we put a pacemaker in somebody with fast ventricular response? Well, it's a good question. We need to slow them down. So in order to slow them down, we can do two things. We can either stop the connection between the top and bottom chambers of the heart, and we do that through RF ablation called AV nodal ablation. Or, and if we do that, they're always going to be paced. Or we can try to medicate them. If we medicate them, sometimes these patients are fragile and their intrinsic response just drops right off. So they're indicated for pacing at that point. So two more examples of fast and slow conduction with AF. Second type, AV block patients. AV block comes in three types. It's a disorder where when the SA node fires, it doesn't conduct down to the ventricle or conducts down in an improper way. So we have first degree AV block, second degree AV block, type 1, second degree AV block, type 2, and third degree or complete heart block. Generally speaking, we do not put pacemakers in for first degree AV block. However, if they have some documented underlying AV nodal disease, they may get them. So an example of normal sinus rhythm on the right, normal timing between the P and R waves. And first degree block, you can see the separation between the P and the R. Typically normal is anywhere from 100 to 150-ish. Getting a little any longer than that, you're starting to get into first degree AV block. It's delayed timing. Well, here it's saying greater than 200 milliseconds for a first degree AV block. Here's an example of normal sinus rhythm and second degree AV block, type 1, where you can see that the P to R intervals increasing, it keeps increasing until finally it causes a drop beat. Type 1 indication for a pacemaker. Here's second degree heart block, type 2, or Mobitz type 2. And as you can see, there's a P wave and drop beats. So every other beat is being captured. And the final, sorry about that, let me go back. And the final type of heart block is complete heart block. And if you look, I don't know if you can see my cursor here or not, but there are multiple P waves here, multiple R waves, but they are totally disassociated. So the top of the heart and the bottom of the heart are not communicating whatsoever. In congenital heart block, we were talking about this early, patients who are born with this and and their conduction systems don't degenerate over time. Sometimes we see them in if you see this is a nice tight QRS, And obviously these P waves aren't associated with it. So that's that's a junctional rhythm, a junctional escape. We'll see that with congenital heart block sometimes. The third and final fun type is neurocardiogenic syncope. These patients can be kind of hard to program for, but I'll show you why. Spontaneous sudden drops in heart rate and blood pressure. Basically, all of a sudden, with no fault of their own, their heart stops, the blood pressure decreases, and they fall out. Long pause and drop in heart rate. Drop in heart rate causes syncope, fainting, or pre-syncope. Pacemakers help. They prevent, they only kick in when the patient needs it. Prevents fainting. I'm not going to get into carotid hypersensitivity. That's a little too much. So guidelines, official guidelines or rules on pacing indications. Current pacing indications are from 2012, and typical diagnoses you can see right there: sinus node dysfunction, any patient with complete heart block, neurocardiogenic syncope, or carotid sinus hypersensitivity. Physicians make the determination. Bottom line is, if we think somebody needs a pacemaker, there are tests that we can perform to verify that they need a pacemaker. We're really, really blessed, especially at Baptist Hospital, and actually the whole city of Pensacola have some pretty amazing electrophysiologists, and it's always a pleasure working with them because I learn something new every day. I've been doing this for about 15, 16 years now. And the cool thing is I learn something new every day from either a patient, a physician, a nurse, somebody. So it's a really cool thing that we do. Guys, that's all I've got for you. At this point, I can open it up for questions. And myself or Matt, I don't know if Haley's on the call. We can all answer questions. If y'all want to fire away, I'll be happy to answer any questions that we had in the presentation. Or Matt and I can sit here and talk.
You see that?
Sorry to jump in, Mark. Oh, I think we're about to say the same thing. It looks like there's a question in the chat from Olga asking, how do you measure thresholds in atria and ventricles prior to pacemaker insertion?
Okay, so that's a good question. We can't. The only way to do it is actually go inside the ventricle at implant. We put the lead in, we place the lead. The physician then hooks up to a device that we use to send electrical signals to the heart and read electrical signals from the heart to determine if it's a good spot in the heart to place the lead. So we might hit the right spot the first time, or we might have to move that lead to a different position depending upon the patient. Good question. Well, I'll jump in here and kind of wait for a few more questions. But listen, if you guys ever have a question, that's what we're here for. That's what we do. Robin has our number. So do the girls in the pacemaker clinic. Feel free to call. There's not a stupid question. Believe me. Like I said, I learn new things every day, and I've been doing this a long time. Matt's been doing this. How many years have you been doing this, Matt?
6 years now?
6 years. Okay, so combined, we have about, let's see, we've got about 22 years of experience doing this. So if you ever have questions, if you ever have, oh, okay, got another. What's the difference between I'm sorry, Olga, this is a great question as well. What's the difference between a single chamber and a dual chamber device? like I said, good question. Dual chamber devices use 2 wires, one in the atrium and one in the ventricle. The reason we do that for dual chamber devices is we want to maintain AV synchrony. So if you ever listen to your heartbeat, you hear a bump, 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 bump. That's the atrium and then the ventricle beating. So people that generally get single chamber devices have something going on in their atrium that we don't want to take into consideration. And those are atrial fib, atrial tachycardia. So we're placing the single chamber devices in people with atrial fibrillation to maintain a constant ventricular beat, because we can't control atrial fibrillation. The only way to do that is either ablate the AV node to stop the conduction or have an AF ablation to take care of that arrhythmia. How do you know if a patient needs to see a neurologist for syncope or pre-syncope? Good question. I'm not a physician, but I'll kind of speak out of my bounds here. Generally speaking, what we're going to do is rule out any kind of cardiac abnormality or problem. Generally doing that, we'll use a 30-day monitor, or in some cases, we'll insert an internal cardiac monitor or loop recorder to determine whether or not they have some underlying rhythm issue. Now, I don't deal with neurologists all the time, so I can't speak to that, but generally from a cardiology perspective, to rule out any arrhythmia, any type of bradyarrhythmia or tachyarrhythmia, we'll do one of those 2 things. Good question. I don't know who that was, but that was a good question. Does insurance cover, this is a good question, does insurance cover a pacemaker insertion entirely? Obviously, yes, for the most part, Medicare, Medicaid, but you're always going to have some sort of deductible to meet in order to do that. But absolutely, insurance do cover pacemaker insertions. Would the result of an SA ablation prompt a patient to have a pacemaker implanted? So we don't really yes, because basically if you're taking away a patient's own internal pacemaker, you've got the triple redundancy, which falls down to the AV node, okay? But that rate is much slower than the typical rhythm that the SA node would have. So instead of going 60 to 100 beats a minute consistently, you would be going 40 to 60 beats a minute, producing bradycardia, and then you would have to have a pacemaker. Now, you don't hear very many SA node ablations. Typically, if they have SA node dysfunction already, we're not going to ablate it. We're just going to put a pacemaker in to maintain their rhythm. Good question, though. How often do pacemakers need to be changed? Our devices, our new device, that's MRI conditional, we're getting battery data up to about 12 years on. It all depends, however, on how much electricity it's taking to make that heart beat. Okay, so if we've got a patient who takes very little, it could go 13, 14 years. If we have somebody with very high thresholds, it could limit that up to 40%. So really depends on patient-specific conditions. Matt, you want to add anything, bud?
Oh, I think you actually did a very good job.
Oh my God. I've some witnesses here to that. That's fantastic. Okay. Well, listen, like I said, guys, if you ever have a question, please do not hesitate to give us a call. we're going to try to do more of these. If this was helpful, we're going to go into some specific, more advanced topics, and we'd love to have you guys listen to us. It's kind of weird not doing it face to face, but I love to teach, and I think what we do is kind of cool. I love to see when patients walk out feeling better than they did walking in. So if you ever have questions, please don't hesitate to ask, and hopefully you'll be on for our next one as well. So thank you. Patrick, you got it, bud?
Thank you so much, Mark. Thank you for all you're doing for our team. I appreciate that. That was awesome. Thanks again.
No problem. You guys have a great day, and we'll talk to you soon.
Thanks.